Hello, myself Dr. Shivani Bansal, Professor at the Department of Medicine in Santosh Medical College Hospital, Ghaziabad. Today's the topic is heart failure. Heart failure is a very common clinical condition and one of the most common reasons for the hospitalization of the patients all over the world. How do we define heart failure? It is a clinical syndrome resulting from structural and functional impairment of the ventricular filling or ejection of the blood. These days, the term congestive heart failure as used previously is no longer preferred. Heart failure is classified according to the three stages, that is, according to the American College of Cardiology, then by NYHA classification. Another classification, which is the currently and the most followed one, is the one based on left ventricular ejection fraction, and last is the classification based on the time course. AHA says divides it into four stages, that is stage A, stage B, stage C and stage D, in which the stage AB, the patients who are at high risk for heart failure without structural disease or symptoms, like patients with diabetes, hypertension or obesity. Stage B is the structural heart disease without signs and symptoms of patients of heart failure. Stage C is the structural heart disease with prior or current symptoms of heart failure, and stage D is the one which is refractory to heart failure requiring specialized interventions. Then NYHA classification classifies it according to the activity, or it's called as a functional classification. It is related with the amount of the activity which the person can do. So first is ordinary activity doesn't cause symptoms. 2. Ordinary activity causes symptoms but the person is comfortable at rest. Then 3. Less than ordinary activity causes symptoms but the person is comfortable at rest. And 4. The person is unable to carry out any physical activity without discomfort. The next classification is according to the ejection fraction, where it is classified as heart failure with the reduced ejection fraction, where the ejection fraction is more than 40% and it is one of the most common one. Then second is the heart failure with preserved ejection fraction, where signs or symptoms of heart failure will be there but the ejection fraction in this condition remains more than 50%. Then usually it is the exclusion criteria and is one of the most non-cardiac causes of symptoms. Then third is the heart failure with mid-range ejection fraction, that is signs and symptoms of heart failure will be present. In this condition, ejection fraction is between 40 to 49%. BNP level will be increased and the person will have diastolic dysfunction. Then according to the time course, the heart failure is classified as acute decompensated heart failure, which is a sudden onset requiring unplanned hospitalization or emergency room visits. Second is the chronic heart failure, where there will be insidious onset of signs and symptoms. Third is a new onset or de novo heart failure. And fourth is the stable heart failure for the treated patients with unchanged symptom status for at least 1 month. Then what are the various symptoms of heart failure? The symptoms of heart failure, why do they actually happen? Most of the symptoms are happening because the cardiac output is decreasing. We can understand it like that. The basic function of the heart is to supply the blood to various organs of the body so that they can work. But if the heart is failing, it's not functioning properly, its pumping capacity is being affected, that when that pumping effect of the blood is being hampered, it will produce various types of symptoms when the oxygen requirement of the body is not able to meet. Then symptoms could be because of pulmonary congestion, because there happens increase in the pulmonary artery pressure. Then systemic congestion can cause various symptoms, or another symptoms could be because of the CNS changes. So the common symptoms of heart failure are fatigability, dyspnea, that is difficulty in breathing, then orthopnea, that is difficulty in breathing in lying down position, paroxysmal nocturnal dyspnea, cough, weight loss may be there because various factors like TNF alpha is increased, which results in cardiac ataxia and muscle mass loss. Then patients may have weight gain also because of the fluid accumulation. Then swelling may be there due to systemic congestion. Then increased abdominal girth. Sometimes patient may have abdominal pain, especially which is located in the right hypochondrium region because of the liver congestion. Person may have early satiety due to gastropathy, which happens as a result of the systemic congestion. Then CNS changes in the heart failure patients could be side strokes breathing, that is there will be episodes of hyperventilation followed by apnea. It happens because of the increased sensitivity of the respiratory center for circulating carbon dioxide, which will cause patient to hyperventilate, which further results in apnea. Or the person can also have somnolences because of hypoxic encephalopathy due to decreased cardiac output to brain. Then how do we determine the cardiac causes of these symptoms? We take the history. By proper history we can determine the cause of these symptoms. Then in these patients, past history of heart failure, asking about the past history of heart failure becomes very important. Then risk factors for heart failure. Whenever we are seeing a patient, we always need to look for the various risk factors, like if the person is obese, if that person is diabetic, if he is already suffering from hypertension, how is its diet, NSAIDs बहुत तो नहीं खाते वो off and on, or the person is on any other drug which is leading to the water retention in the body. Then systemic diseases need to be looked for that can affect heart, like amyloidosis and sarcoidosis, and history of other diseases. Sometimes a simple viral infection, like we had a lot of patients of COVID who had post-COVID myocarditis or dilated cardiomyopathy. Then family history, asking the family history is also very important. The family history related to the heart failure and of sudden cardiac death. Then environmental and medical exposure to cardiotoxic agents, like patients on chemotherapy. For example, patients on doxorubicin may develop cardiomyopathy. Then coming on to the after the symptoms, the next thing is what signs will you find in the patient of heart failure. The person can have pallor, that happens because of the hypoperfusion. Then cyanosis. It is central cyanosis develops in these patients because of pulmonary edema, which leads to hypoxia, and sometimes peripheral cyanosis can also be there because the cardiac output is low. Then stigmata of alcohol abuse, like spider angioma, Palmer arrhythmia, etc. Then erythema nodosum from sarcoidosis or bronzing from hemochromatosis. Then patients who had existing amyloidosis may have easy bruising, and these patients commonly have pedal edema. Then when we do the cardiovascular system examination, the pulse rate is increased, and actually tachycardia is one of the earliest signs of the heart failure, and it happens because of the sympathetic nervous system activation. Then narrow pulse pressure, also called as the thready pulse. Then pulsus alterans, which is the regular alteration of the pulse amplitude. JVP, elevation of the JVP again is very important and has a sensitivity of approximately 70%. Then in these patients of heart failure, when we examine for the apex beat, it may be diffuse, and it's most commonly it is found diffuse, that is it occupies an area of more than 12.5 centimeter. It could be displaced if the heart is hypertrophied, like in cases of volume overload, and if sustained, then it happens because of the pressure overload. When we do the cardiac auscultation, S1 is usually soft and S2 in cases of left ventricular failure, the A2 will be little late and reverse split may be present. If S3 if present is suggestive of the systolic failure, and presence of S4 indicates diastolic failure. Then certain murmurs may be present like the mitral regurgitation murmur, which is the most common and happens due to mitral valve annulus dilatation. Respiratory findings may be presence of creps especially in the bases, and these are inspiratory fine creps. Sometimes bronchi may be present because of the edema in the air wall, and abdominal examination may reveal hepatomegaly and ascites. Now coming on to the investigations part. In the investigations, electrolytes are very important because decreased sodium. There may be presence of decreased sodium because of dilutional hyponatremia or decrease in the potassium. Blood urea nitrogen, serum creatinine may be affected. Hepatic enzymes like may be raised. Prothrombin time may be raised and serum albumin is decreased. Then fasting lipid profile, blood sugar, these are to be done. HbA1c, urine, these are the other routine investigations to be done. Then what are the various biomarkers of heart failure? The biomarkers consist of various natriuretic peptides like the ANP, BNP and NT-proBNP. They are higher, these biomarkers are higher in the heart failure with the reduced ejection fraction than the heart failure with preserved ejection fraction. Other biomarkers, they are under other newer biomarkers also like the soluble concentration of ST2, then galactine 3, TROP-T and TROP-I may be elevated in patients of heart failure and absence of acute coronary syndrome. In the imaging test, chest X-ray for assessing the pulmonary edema and to rule out the pulmonary causes of dyspnea, echocardiography to assess the ejection fraction, which is very important and helps in classification and the prognostication of the patient. Echo also gives us a very good idea regarding the diastolic functions of the heart, and then cardiac MRI may be required for some patients, especially for the patients with cardiomyopathies where it's better than echocardiography. Then next imaging test which could be done is pulmonary artery catheterization. Now coming on to the acute heart failure, which is one of the most common emergency which we deal. So acute heart failure is further classified as a decompensated heart failure, which is the most common presentation, which presents as sudden onset edema, orthopnea or PND. In this condition, systolic blood pressure may be variable. Or another presentation is with the acute hypertensive heart failure, where also the patient usually presents with dyspnea and this systolic blood pressure is elevated and the chest X-ray shows the presence of edema. But this responds well to the treatment. Third type of acute heart failure could be cardiogenic shock, where the patient will have oliguria and cold extremities and the systolic blood pressure will be less than 80 millimeters of mercury, lasting for more than 30 minutes. Then how do we manage these patients of heart failure? The management, whenever we are managing how much congested the patient is, assessment of that thing is very important. If the patient is congested, we confirm it by the presence of the creps in the lung, pedal edema, ascites. If yes, then and peripheral perfusion is good, that is the peripheries are warm, then the first treatment given is the diuretics like injection furosemide and vasodilators. What do? They will reduce the afterload, so the perfusion will increase. If the patient is congested but the peripheral perfusion is less, in those cases if the systolic blood pressure is more than 90, then diuretic and inodilators are given. If systolic blood pressure is less than 90, then inotropes, vasopressor and diuretics. If no response, mechanical circulatory support is required. Second condition is where the person is not congested, that is there are no creps, there is no pedal edema, there is no ascites. Then also in that case, a dry patient of heart failure, Then we assess the peripheral perfusion. If it is good, then adjust the oral therapy. If the peripheral perfusion is less, then give IV fluids. If no response, inotropes are given for the treatment. Then other modalities of treatment for these patients are giving the mechanical circulatory support for the patients, like intra-aortic balloon pump or left ventricular assist devices for the critical respiratory cases. Oxygen administration is required with the patients who have severe hypoxemia, and if the SaO2 on presentation is inversely related to the short-term mortality. The inhaled oxygen causes adverse hemodynamic effects and it causes hypoxia-induced vasoconstriction, especially in patients with systolic failure. Then another drug which is very useful for patients of acute heart failure is morphine. What does it do? It decreases the preload by shift of the alveolar fluid to the blood vessels, and it also allays the anxiety and the distress which a patient of heart failure is experiencing. But it cannot be used for the patients with hypotension, bradycardia, advanced AV block or CO2 retention. Then just a word on the newer drugs for acute heart failure. First one being the serelexin, which causes the improvement in the cardiovascular mortality and it's a vasodilator drug. Then second are the natriuretic peptides like urodilantin, which is a modified version of pro-ANP. Then urelitide, which is a synthetically produced urodilantin 3. Then tenzosentan, which is a non-selective endothelin AB antagonist, and it improves the hemodynamics in patients with acute heart failure. Another drug, a newly developed or the experimental drug for heart failure is omecamtiv mecarbil, which is a cardiac myosin activator. And another is istaroxime, which increases the calcium concentration and stimulates the membrane bound sodium potassium ATPase. Now some of the causes of the patients of heart failure with reduced ejection fraction. The commonest cause of patients with heart failure with reduced ejection fraction is the myocardial diseases like coronary artery disease. Then conditions with the chronic pressure overload like aortic stenosis, chronic volume overload like AR-MR, non-ischemic dilated cardiomyopathy, rhythm disorders, chronic nature of bradycardia and tachycardia, pulmonary causes like copper-pulmonale and pulmonary vascular diseases, and metabolic causes like thyrotoxicosis. The patients, as we discussed in the initial slide, a patient with this stage A, we classified a patient of stage A when the person has high risk of developing heart failure but still have no symptoms or no structural defects. So who are these patients who are at risk? These are the patients who are hypertensive, who have atherosclerotic disease, patients with diabetes, obese persons, metabolic syndrome, patients who use cardiotoxic drugs, and a family history of cardiomyopathy. So what should be our advice for such persons or such patients? They should keep their blood pressure well within control. Optimum BP of less than 130/80 mm mercury is advised. Salt intake should be monitored, should be less than 1.5 gram per day. Drugs like ACE inhibitors or angiotensin receptor blockers for hypotension. Glycemic control for the diabetic patients should be optimal, and statins are very good drugs. They have a very positive action on the heart, so they may be indicated wherever and whatever dose indicated. Then patients who are in stage B of heart failure, that they already have the structural defect, here also the optimum BP should be less than 130/80. Salt intake should be less than 1.5 gram, and heart failure with reduced ejection fraction, patients should be put on ACE inhibitors or ARBs and beta blocker. In patients with acute coronary syndrome and MI, statins are initiated. Then the patients with stage C, that is patient already has a structural heart disease and the symptoms have already developed. Sodium can be given in a dose of 2 to 3 gram. Fluid should be restricted to less than 1.5 to 2 liters per day. If the patient in hyponatremic patients or refractory fluid retention, then these are the patients who are unable to control with the diuretics. For the stage C patients, the drug of choice now are the ARNI drugs. If the ARNI is not available, then in those cases, combination of ACE/ARB plus beta blocker plus diuretic may be used. Though ARNI is very commonly available with us now, and its rate has also decreased quite a lot. Then second step, if patient is in NYHA 2, then add 2 to 4 NYHA में है तो add aldosterone antagonist if potassium is less than 5 and eGFR is more than 30. If patient still in NYHA 2 to 4, then add SGLT2 drug inhibitor irrespective of the diabetes, and if patient still in NYHA grade 2 to 4 and resting heart rate is more than 70, then add drugs like ivabradine. If patient still still in NYHA grade 3 to 4 and no improvement after above mentioned therapy, add hydralazine plus isosorbide dinitrate and a second diuretic. Then third step is after 3 to 6 months echo is done, and if ejection fraction is less than 35%, go for device therapy or implantable cardioverter defibrillator to reduce the risk of sudden death, or a cardiac resynchronization therapy. If patient is on ACE inhibitor, then give 36 hours to start the ARNI to prevent development of angioedema. Aldosterone antagonists which are used are spironolactone or eplerenone and phenomenon. In the stage D patients, or if the patient still not responding or is refractory, then treatment which is given is the inotropic support, a temporary one, or sometimes a continuous inotropic support may be required if the patient is awaiting for the cardiac transplantation. And during this waiting for cardiac transplantation, mechanical circulatory support is also given. Then patients, lastly the patients with the preserved ejection fraction, if these are older patients, the causes are usually hypertrophic osteotrophic cardiomyopathy or restrictive cardiomyopathy or a pericardial disease. Then treatment is usually given with the diuretics to relieve the symptoms of volume overload and coronary revascularization. Then in cases if the patient is hypertension and has developed heart failure, the drug of choice is beta blockers or ACE inhibitors or ARB in appropriately selected patients with heart failure with preserved ejection fraction. The role of aldosterone antagonists are for those patients who have eGFR of more than 30, creatinine of more than 2 and serum potassium is less than 5. So that is about the heart failure, which is a very common clinical syndrome encountered in day-to-day practice with all the clinicians, as well as it's a very important topic for the exam point of view, both in the theory and the practical examination. Thank you.